Hi, today I will talk about Parkinson's disease pathophysiology and pharmacology. Although it is the second most common neurodegenerative disease out there, Parkinson has a complex and not fully understood pathophysiology. There are two primary hallmarks for the Parkinson disease. The first one is the degenerations of neurons in substantia nigra pars compacta, and the second one is accumulations of Lewy bodies in the brainstem. Dopamine deficiency, oxidative stress, excitotoxicity, and neuroinflammations are mainly associated with the neurodegenerations. However, these processes are also influenced by the presence and accumulations of Lewy bodies. All these factors interplay with each other to enable the pathologies of Parkinson. Although Parkinson's disease is idiopathic in most patients, genetic and environmental factors such as exposure to pesticides use, solvent, heavy metal, air pollutions can also link to the disease. Here is the brain and the affected area, the corpus striatum and substantia nigra. We will talk about the first hallmark, which is the nerve cell loss in the brain, specifically in the substantia nigra of midbrain. As mentioned, there are several factors contributing to this problem. As you can see here, there is a decrease in the glutathione, the brain primary antioxidant, which leads to the oxidative stress, come along with the inflammations. This creates a decrease in the dopamine level in corpus striatum. And this loss results in the disruptions of normal information's flow through the basal ganglia. Now, we have several common neurotransmitters such as dopamine, acetylcholine, GABA, glutamate, and so on, but the decrease in dopamine creates an imbalance between the dopaminergic, cholinergic, GABAergic, and glutaminergic activity. Consequently, it affects the control muscle tone and voluntary motor, resulting in the Parkinson clinical manifestations such as tremor, bradykinesia, rigidity, postural instability. It is notable that patients who shows motor symptoms when roughly 50 to 80% of all necrodopaminergic neurons have degenerated already. Now, this is a diagram to show the comparison between normal and Parkinson dopamine pathway. In a healthy person, dopamine released from the neuron originating in the substantia nigra inhibits the firing of neurons in the striatum that release GABA. Conversely, neurons located within the striatum, which release acetylcholine, excite the GABAergic neuron. Under the normal conditions, the inhibitory actions of dopamine are balanced by the excitatory actions of acetylcholine, and controlled movement result. But in the Parkinson disease, the neuron that supply dopamine to the striatum degenerate. When there is a deficit of dopamine, the excitatory effect of acetylcholine go unopposed, resulting in the disturbed movement such as tremor or rigidity. The second hallmark is the accumulations of Lewy bodies. These aggregates have been observed both inside and outside of substantia nigra. Normally, alpha-synuclein is a neuronal protein known to have several physiological roles in the human muscle, brain, heart, and other tissues. But extensive aggregations leads to neurotoxicity. These clump of protein are thought to contribute to disruptions of normal neural function in Parkinson's disease. It is reported that this protein is the key part in Parkinson pathogenesis, which include three major pathways: the vesicular trafficking, lysosomal functions, and mitochondrial maintenance. These three pathways are also linked with abnormal activities of several genes, as shown in this flowchart. There are a lot more genes that involved in this pathology, but I only show you the main one. Unfortunately, until now, we haven't had any conventional treatment that can reverse or fix the progressive pathology of degeneration in Parkinson's disease. because too many unknown factors, the complexity of disease itself. And as I mentioned before, once the patient already showed the motor symptoms, it means significant neural damage has been done and is irreversible. However, we can manage the symptom of this disease. One of the most common drugs for Parkinson is levodopa with carbidopa, generic name, or Sinemet or Kinson in brand name. This medications is the dopamine precursors, and also this is the gold standard in the Parkinson. It helps to replenish the dopamine level in the basal ganglia by being converted into dopamine. So, as I mentioned before, a decrease in dopamine is a major hallmark of this disease, so levodopa can relieve the symptom, particularly rigidity and bradykinesia. Cinemas is absorbed through the GIT tract and metabolized, then converted into dopamine mostly, and to adrenaline and noradrenaline in lesser amounts. The adverse effect of Cinemat can include motor complications, specifically dyskinesia and fluctuations, mental changes such as sedations, hallucinations, and delusions. Another common but less serious effect is nauseous, vomiting, and orthostatic hypotension. Nursing considerations for this medication is it should be given to the patients at the same time each day, 30 minutes to 1 hour after meals, to maintain the stable blood level and avoid fluctuations. Avoid MAO, monoamine oxidase inhibitors, as this can lead to severe hypertensive reactions. Avoid anticholinergics and antihypertensive, as those can enhance the adverse side effect. Avoid D2 receptor antagonists, such as risperidone, because it may reduce the therapeutic effects. Thank you.